Okay, fine. Thanks much for this opportunity. So I'm going to talk on conservative approach. So a couple of months back, a friend, ophthalmologist friend, called me up and said, "Because what do you generally do for the ulcer who are not responding? Means a stain is positive and it is not, healing. I've heard about AMG. Can I just get the AMG and place it?" So what he wanted to ask her was a blanket statement that if there's a stain positive for a couple of weeks, can you use AMG for these cases or one modality? So I think this question was a bit incomplete. The better framing would be, how do I approach a patient who has an epithelial defect and that epithelium which is not moving? So that's what I'm going to talk about, the conservative approach. How do we, assess when we stop and see what is going on in there? So first of all, why do we really bother that if the epithelium doesn't come up? So what is the main issue? So this patient who had resolving microbial keratitis referred to us for he had a history of 3 to 4 weeks. You can see the epithelial which was not moving has led to melt. Another such patient. So if you have a PED for long standing, it may lead to collagenolisis. This lady, due to some domestic issues, her eye drop, the regular eye drop was replaced by acid. So she was instilling acid eye drop for 1 month. And when she was rescued, this was how, she presented. So we need to get worried if this epithelium is getting heaved up and not crawling and not covering the defect that has been created. So why epithelium is not moving, that is you need to ask in your patient. And for that, we need to know how the epithelial defect heals. So when there is a defect, first of all, there is a migration, and then these epithelial cells proliferate, and then they anchor with each other and the underlying basement membrane and stroma. And there's a gamut of growth factors that plays a lot of role here. So for epithelium to move, you need a healthy limbus, healthy corneal epithelium, and then a lot of growth factors, and then tear, which will keep on washing away the desquamated epithelium, and good atmosphere, environment, the whole milieu, that is very important. And this epithelium is dynamic, just like a runner. A runner if you want to do a marathon, you need to have good muscles, energy drinks, hydration, and environment. What is the environment? If it's a good encouraging atmosphere, then the epithelium can really crawl up well. So if you have this stain positive for more than 2 weeks, you need to get worried, and that is what you can call persistent epithelial defect. So what are the management modalities? So hydration, you need we have lubricants, punctal plugs, and then Botox or tarsorrhaphy. Again, the whole atmosphere will become more supportive. BCLH debridement, autologous serum. So the lubricants, as I said, these are the first line. If the basic etiology has been taken care of, first is lubricants, then punctal plug if the dry eye is the main issue, then tarsorrhaphy if there's a lag of thalamus. Again, it is going to improve the overall atmosphere, the environment for the epithelium, and decrease the IPF. We have high decay value bandage contact lenses. If you have the epithelium which is not resolving even to lubricants, can think of BCL and edge debridement if the heaved up epithelium that you just need to remove it. And then autologous serum, if if lubricant is not working, you can fortify it with the autologous serum or fortify it with the growth factors. You can use we need to use the patient's own blood and centrifuge it for 300 rotation for 10 minutes, separate the cellular from the acellular component. So aspirate this serum, which is the acellular part, and mix it with the normal preservative-free lubricants. We generally use 2 ml of autologous serum and 8 ml of preservative-free lubricants, and your autologous serum is ready. So it's quite easy, and these will become fortified lubricants. So we need to see, it's very important to check the cause. What is the cause, and treat the cause. So for example, this patient who had this, he was on epithelial antibiotic. There was an epithelial defect for more than 2 weeks. So when we saw the UTC, so there was a foreign body. So this was hostile. It was not letting the epithelium move. So whenever there is a epithelial defect, persistent epithelial defect, need to see if there is any mechanical cause, any foreign body, lids, entropion, trichiasis. So that becomes important to, before we jump in for our surgical management. Again, this lady was on, multiple, she was on netamycin, acyclovir, moxifloxacin, tobramycin, We stopped all the medication and just gave lubricants, and you can see the whole thing become cleared within 3 weeks time. So sometimes these heaped up epithelium, which are due to, this was patient again who was on natamycin, and you can just remove these heaped up edges, place a bandage, contact lens or lubricant, this becomes all right. Chemical injuries, again, here there is a lot of inflammation going on, and that's why the epithelium is not coming up. Here, yes, I'll have a low threshold for AMG, but sometimes, even with AMG alone, it doesn't work. So this patient, we had done AMG twice, but the epithelium was not coming, and we had to do tarsorrhaphy, and then only it started resolving. As Dr. Nikhil mentioned, these days we do amniotic membrane along with tarsorrhaphy. If you have a microbial keratitis, that is the cause. You need to treat the microbial keratitis and not think about some other modalities of dealing with persistent epithelial defects. Shield ulcer, there's a lot of inflammatory mediators which are coming from the UTC. So if there is no plaque, you can just remove this, debride the edges, place a bandage, contact lens, and treat the cause. So if the inflammation is the cause, need to treat the inflammation, maybe with the supratarsal steroid injection. Sometimes the graft function disparity, so the area on which the epithelium has to move, that is so irregular. Here we have to remove the sutures, do a resuturing, make it smooth, then only the epithelium will start moving. Limbal stem cell deficiency, the inherent strength, the main limbus is defective, you need to treat it with a stem cell transplant or LO or auto, whatever is the thing. So acute SGS, there's a dry eye, there's an inflammation. So the whole atmosphere is hostile and not letting the epithelium. You have to deal with the inflammation, and then you come, or dry eye, and then you come for the taking care of the epithelial defect. This lady, recurrent melts, autoimmune, and the epithelium coming up. Here again, you might need to use, as Dr. Nikhil was mentioning, and here only to work beautifully well. So this patient had a metaherpetic corneal ulcer after HSV. So you need to take care of the primary etiology, and then you think that what modality you want to use. Corneal degeneration. This patient had a spheroidal degeneration. Again, the basement membrane or the underlying stroma is irregular. That's why this epithelium is not coming up. You need to debride it and then place BCL or lubricant. And sometimes ABMD, that also causes persistent epithelial defect. So you need to take care of that part as well. Sometimes Dellen causing tear film abnormality and epithelial defect. Again, you have to give maybe bandage, contact lens, and lubricants. So to conclude, you need to see what is the cause. That is extremely important, and treat the cause. It's not a blanket statement that AMG or any modality for one particular. You need to customize it, and you need to ensure that which management modality you want to choose. Ensure that the limbus is healthy, there are good growth factors, good tears, and overall atmosphere is good. So ensure that your epithelium keeps running. This was a very good review article that I came across. So again, approach, you need to ask for each patient how you are going to approach an individual patient. Thanks so much. My acknowledgements to my fellows and Prashant and Dr. Sangwan for the graph I've used. Thank you so much.
Thank you very much. Dr. San, shall I go on to the next speaker, as both the speakers seem to have explained it all? Or would you have...
No, I think very, very good coverage of all the important points. I would just mention one thing in addition to all the conservative measures that Vikas mentioned. And it is true that you need to know what the conservative measures are, because as Dr. Nikhil rightly said, the AMG works very well in these cases, but may not necessarily be available for everybody. So you need to know when to use a BCL, just a BCL, or tarsorrhaphy, autologous serum, and all of these. The other thing that I found useful, particularly in patients with SJS, with PEDs where melting has started, is that if you can arrest the melting with a simple thing like using a tissue adhesive, that itself stops the necrosis and allows the epithelium to heal. So in certain cases like failed grafts with PEDs or SJS with PEDs, tissue adhesive application also helps in arresting the necrosis and aiding the epithelialization. That is the only thing that I think I had to add. Thanks.
Thank you. So thanks a lot.